Okay, so let's do some practice. So here's a case where we open it up on CT in axial images at the level of the carina. And again, we look at this lung here, and we can see that there's going to be several micronodules throughout the lung. Again, these are going to be less than 5 millimeters in size. So one of the first things we could do is just look at the appearance, and we note that these are ground glass nodules. That in and of itself is going to be a pretty big clue. We said that the only micronodule distribution that can be ground glass is typically central lobular. So that should be a pretty big clue as to what we're looking at. But let's see if we can apply this algorithmic approach, and let's see if that holds true. So the very first question we ask is, does this involve the fissural or pleural surfaces? And if you look here, you can see that largely the edges of the lung are relatively spared. They look pretty black throughout. When we look here, we can see that there are these ground glass nodules, and when we look at these ground glass nodules, they're fairly evenly spaced and distributed throughout the lung. So we see evenly spaced ground glass nodules that are sparing the pleural edges. This is what we would say is a centrolobular distribution of pulmonary nodules. So this is a centrolobular distribution of pulmonary nodules. This is an example of centrolobular disease. What about this case? So the very first question is it involving the fissural or pleural surfaces? And if you look here, you can see that there are dots along the fissures. So we automatically know that this cannot be centrolobular nodules, not centrolobular nodules. The next question is it clustered, or is it kind of evenly spaced throughout the lung? If the answer to that is yes, then we're going to be dealing with perilymphatic. If the answer to that is no, then we're going to be dealing with randomly distributed. So let's see if we could try to figure that out. So if you look at these nodules, you can see that they're along fissural surfaces. We can also see that there's lots of nodular thickening along a bronchovascular bundle here, as well as along septae within the lung. So this looks like a pattern of clustered nodules along lymphatic distributions. So the answer is yes, these are clustered. Therefore, we're dealing with perilymphatic micronodules. This is an example of perilymphatic micronodules. Here's another case. So again, we are dealing with micronodules. So we see several nodules that are measuring less than 3 to 5 millimeters in size. So the first question we again ask, is it involving the fissural and pleural surfaces? And if you look here, you can see that there are nodules here along the fissures and involving the pleural surfaces. Therefore, we know that this again is not going to be centrolobular disease. It's not going to be centrolobular nodules. The next question is it clustered? So if the answer is yes, it's perilymphatic. If the answer is no, meaning more evenly distributed, then we're going to be dealing with randomly distributed pulmonary nodules. And if we look here, everywhere we look in this lung, so if we just take a section of this lung, and then take a section of this lung, we take a section of this lung, when we look in each of these sections, the amount of nodules are fairly evenly distributed throughout. The amount of nodules in this section are about equal to the number of nodules in this section. So this is what an evenly distribution of nodules throughout the lung looks like. And because they're involving the fissural and pleural surfaces, we know that we must be then dealing with a random distribution of pulmonary nodules. So this is a case of a random distribution of pulmonary nodules, also known as a miliary distribution of pulmonary nodules. Miliary from the word millet, which is basically a type of grain, and these grains are really small in size, and they look like these tiny little nodules. Okay, here's another case where we can see that there are nodules in the lung. So we see them here. So the first question we have to ask, is it involving the fissural and pleural surfaces? And so this is a little bit tricky, so let's take a look here. So one does closely approximate, but it's a pretty big nodule, right? So that doesn't really count. When we have big nodules like this, they can occupy the whole secondary pulmonary lobule, and it can be difficult to differentiate that from either a perilymphatic nodule that's involving the edge of the secondary pulmonary lobule, or an acinar nodule. An acinar nodule being a larger size central lobular nodule that's involving a larger portion of the secondary pulmonary lobule. So let's keep looking. Well, this fissure here looks really, really clean, despite there being nodules adjacent to it. And let's look at this pleural edge over here. So this pleural edge over here also looks really clean, despite there being nodules immediately adjacent to it. So I think in this case, we could say that there is sparing of the fissures and also sparing of the pleura. Therefore, we're going to be dealing with central lobular nodules. So these central lobular nodules that we see here are solid. And we could also see that some are ill-defined, like these nodules in here. So there's also ground glass nodules. And then you can also see some kind of branching nodular opacities. So that's these areas in here. These are what you call tree and bud opacities. So these are your branching nodular opacities within the lung. These are tree and bud opacities. So there's also tree and bud opacities. These are all features of central lobular disease. So it's another case of central lobular nodules. And lastly, a little bit more of a subtle case here. So again, at first glance, there doesn't look to be much going on in this lung, but if you look closely, you can see that there's some subtle nodular studding of the fissure here, some very subtle nodular studding of the pleural edge. And if you look at the bronchovascular bundles, they don't look smooth, do they? Right? So here's a bronchovascular bundle. Here's another one. And you look at the edge of it, it just looks like it's a little bit nodular, just a little bit nodular in here. So again, we have nodules. They're involved in the fissural surfaces, they're involved in the pleural surfaces, and they're clustered along a distribution. Therefore, we must be looking at perilymphatic nodules. So this again is a case of perilymphatic micronodules. Okay, so now I hope you guys are able to differentiate when looking at a CT via an algorithmic approach how to approach micronodules. The first step again is going to be to look if it involves the fissural and pleural surfaces. If the answer is no, and it clearly spares those, then you're dealing with central lobular disease. Central lobular disease can either be ground glass, solid, or tree and bud in appearance. If it does involve the fissural pleural surfaces, the next question you have to ask is it clustered? If it's clustered along a particular distribution, bronchovascular, septal, fissural, or pleural, you're dealing with a perilymphatic distribution of micronodules. If it tends to be evenly distributed, but also involving the fissures and pleural surfaces, then you're dealing with a random distribution of pulmonary nodules. So now that we've established how to approach pulmonary nodules, what is our differential for these micronodules? So when we think about miliary or random pulmonary nodules, we want to think about hematogenous disease, so hematogenous spread of disease. So what are the things that could spread hematogenously? Well, some infections can. So the big infections here are endemic fungi. So endemic fungi being like blasto, cocci, and tuberculosis. So tuberculosis is another infection that commonly spreads via randomly, and that's your quote miliary tuberculosis. So that's a miliary pattern of nodules throughout the lung. And you can clearly see that with TB. You could also see it with endemic fungi. And endemic fungi are different than opportunistic fungi. Opportunistic fungi are things like invasive aspergillosis, mucor in Canada. So we're talking about endemic fungi. And then the other big category here is metastatic disease. So the classic metastases that are associated with a random distribution of pulmonary nodules is thyroid. We see this very commonly. We also see it with renal cell carcinoma, breast cancer, melanoma, and sarcomas. So we also see the big ones that you have to think about here for a miliary distribution of metastasis, again, are thyroid, melanoma, renal, and breast cancer, as well as sarcomas. Now, there are some rare ones. So sarcoid is typically going to be associated with a perilymphatic distribution, but if you have tons and tons of nodules in the lung related to sarcoid, it can mimic. So it actually is mimicking a miliary or random pattern of pulmonary nodules. And lastly is pulmonary Langerhans cell histiocytosis, and the same applies for this. Pulmonary Langerhans cell histiocytosis typically is going to be more of an central lobular distribution. It can look random as the disease progresses, but again, it's only when the disease gets really severe. So we're not going to typically think about these when we see a widespread micronodular pattern of lung disease. Okay, so let's talk about perilymphatic. So what are the diseases that can be perilymphatic in distribution with multiple small nodules? So the big one here that you have to know is sarcoidosis. When you see perilymphatic micronodules on a CT, one of the first things that you should think about is sarcoidosis. When you begin your training, you almost want to say sarcoid and silicosis both begin with the letter S in the same breath because they share very similar imaging overlapping features. They have lots of imaging overlap. So some of the pneumoconioses like silicosis, co-workers pneumoconiosis, and borreliosis will look very similar to sarcoid. So when we say sarcoid, we always want to think sarcoid/silicosis, especially when you're in your earlier training until you learn some of the subtleties of how to differentiate these two etiologies. So sarcoid and silicosis certainly come to the top of the list for perilymphatic micronodules. Another big one is lymphangitic tumor. So lymphangitic tumor is where you have tumor spreading through the lymphatics into the lungs, and that makes sense as to why we get perilymphatic nodules, again, because it's spreading into the lymphatic distributions. Now, there are some clear differences between sarcoid and lymphangitic tumor. It's usually not difficult to differentiate between these two entities in class, and at the board, we'll be discussing how to differentiate between these entities in a more structured fashion. But as a quick overhaul, sarcoid will tend to predominate with multiple small nodules. It can be also associated with architectural distortion because it could lead to fibrosis. Lymphangitic tumor, while it does have micronodules, often will have lots of smooth septal thickening superimposed on a background of perilymphatic nodules. And it's that smooth septal thickening that really sets it apart from sarcoid. In addition, lymphangitic tumor is typically not associated with architectural distortion of the lung. There's usually not a lot of architectural distortion associated with lymphangitic tumor unless the patient has been radiated or the tumor is obstructing an airway and causing atelectasis. Then there are some rare things. So LIP, that's lymphocytic interstitial pneumonia. And LIP comes in two forms. There's both a cystic form and then there's this kind of perilymphatic form. The cystic form, we often associate that with connective tissue disease like Sjogren's syndrome. The perilymphatic form is more typically associated with childhood HIV. So when we think about LIP and perilymphatic micronodules, it's really the form that's associated with HIV, not the form that's associated with autoimmune diseases like Sjogren's disease. And then lastly is amyloidosis. Amyloidosis has several different forms that it can predominate in the lung. There's a nodular form. There's kind of a diffuse form. There's an airway-related pattern that you can see with amyloid. So in any case, amyloid can produce a perilymphatic distribution of micronodules within the lung. The big three that you should know, though, are sarcoid, silicosis, and lymphangitic tumor. Those are going to be your big three that you must know, at least at the end of your first rotation. So let's talk lastly about central lobular disease. So central lobular disease is a little bit tricky just because the differential here is extremely broad. Extremely broad. When I say central lobular disease, the very first thing I look for is the presence of tree and bud opacities. If you see tree and bud opacities, you're generally thinking about three big causes. You're thinking of first, as a general cause, about endobronchial spread of something. When you see tree and bud opacities, you want to think that something is spreading via the airways. So what can do that? So infection can do that. So any type of small airway infection can do that. It was classically associated with atypical or mycobacterial infections. We now know that any community-acquired infection, typically viral or bacterial, can produce tree and bud opacities. When you see tree and bud opacities, one of the first things you want to think about is just some sort of small airway infection. You could also see this with aspiration. So people that have lower lung zone predominant tree and bud opacities that are dependently located, we'd certainly think about aspiration there. We could also just see this in the setting of bronchiectasis. So people that have abnormal airways that are dilated, stuff can get stuck in them. When stuff gets stuck in them, you can develop tree and bud opacities. There is some rare things that can spread via the airways, and one of these is adenocarcinoma. So an adenocarcinoma of the lung can spread via the airways and result in tree and bud opacities. That's very rare, and certainly we wouldn't think about that unless the patient has a known adenocarcinoma, and even then we'd wonder if the patient was just infected in the interval, maybe to get a short-term follow-up CT to see if those nodules had resolved. If they continue to grow in conjunction with the primary tumor, then almost certainly you're looking at endobronchial spread of disease. Lastly, there's a rare condition called follicular bronchiolitis. Follicular bronchiolitis can be associated with tree and bud opacities, but you almost never, follicular bronchiolitis is a non-infectious type of bronchiolitis, And you'll see this in people that have connective tissue diseases like rheumatoid arthritis. So not an infectious bronchiolitis. It is a type of bronchiolitis though, and it's typically associated with autoimmune diseases. Okay, so I see central lobular nodules. The first thing I look for is tree and bud opacities. If I see that, I'm thinking infection or aspiration, unless the patient has bronchiectasis, in which case it could be related to that. Or if the patient has a cancer and these nodules are enlarging in conjunction with that cancer, then certainly it could be related to endobronchial spread of tumor. But again, the big ones here are infection and aspiration. If there's no tree and bud opacities, the next question I ask myself is, are they clustered? And if they're clustered central lobular disease, then again, generally you're keeping the same differential. It's something usually related to infection or aspiration. Lastly, I look to see, if they're not clustered, there's no tree and bud, I look to see if they're just ground glass and scattered throughout. If they're ground glass and scattered throughout, the next question I ask is, are they acute or subacute or chronic? If they're acute, we can think again about infection, but we can also include pulmonary edema, as well as alveolar hemorrhage. If they're subacute or chronic, it's either something related to the airway, or it's something related to the artery. So what are some airway-related problems that can produce central lobular ground glass nodules? So the big two are respiratory bronchiolitis, and we see this exclusively in smokers, as well as subacute hypersensitivity pneumonitis. So these are going to be your big two for airway-related. Generally, when we see subacute to chronic central lobular ground glass nodules, we think about either respiratory bronchiolitis, so we want to see a history of smoking, or subacute hypersensitivity pneumonitis. Now, rarely it can be associated with something wrong with the pulmonary artery. So in this case, if we see an enlarged main pulmonary artery in conjunction with central lobular nodules, then we think it's a manifestation of pulmonary hypertension. So pulmonary hypertension alone can produce central lobular nodules. So if you see central lobular nodules with a very dilated main pulmonary artery, or someone that is known to have pulmonary hypertension, then we could usually assume that those central lobular ground glass nodules are associated with the pulmonary hypertension and not related to an airway abnormality. Okay, so again, real quickly, central lobular disease, start with tree and bud opacities. If present, we're thinking infection or aspiration. If they're not present, are they clustered? If they're clustered, again, we're generally thinking infection or aspiration. If they're not clustered and they're more evenly distributed throughout the lungs, then we have to wonder, is this an acute or subacute or chronic process? If it's acute, infection, pulmonary edema, alveolar hemorrhage are all possibilities. If it's subacute or chronic, then it's either something related to the airway or to the artery. The airway abnormalities predominate, the two big ones being respiratory bronchiolitis and subacute hypersensitivity pneumonitis. If the patient has features of pulmonary hypertension, then we're typically looking at sequela of pulmonary hypertension. So in conclusion, there are three patterns of micronodular lung disease that you have to know. There's perilymphatic, there's random, and there's central lobular. So when someone asks you what are the three patterns, it's these three: perilymphatic, random, and central lobular. They each have a unique relationship to the secondary pulmonary lobule, and we can use that relationship to develop an algorithmic approach to differentiating them on CT. Again, it begins with, does it or does it not involve the pleura? If it does not involve the pleura, then we're thinking about central lobular disease. If it does involve the pleura, are they clustered or evenly distributed? If it's clustered, it's perilymphatic. If it's evenly distributed, it's random. And then we have to know that there's a differential for each and how to approach that differential. Here's some additional reading assignments. There's a good paper here, as well as a chapter within the high-resolution CT book. If there's any questions, that can be reached by email. Thank you very much.